Welcome and thank you for joining today's Former Worker Medical Screening Program webinar on colorectal screening. Colorectal screening is one of the tests that is offered by the Department of Energy's Former Worker Program. My name is Miles Fisher. I serve as the Program Director of BTMed, the Building Trades National Medical Screening Program, which is one of the 5 Former Worker programs. I'll be moderating the webinar today. Before we get started with the presentation, I'd like to go over a few housekeeping items. The webinar is being recorded and will be posted on the DOE Former Worker Program website, where all of our previous webinars have also been posted. So you can see all the subjects we've already touched upon, from spirometry to beryllium, etc. Also, during this webinar, I'll be posting links in the chat to take you to the Former Worker Program website and also take you to a list of all the sites that are covered and which programs cover them so that you can see that information as well. In the next couple of weeks, you'll receive an email with a link of this recording along with the links that I put in the chat. During the webinar, all attendees are automatically muted and the video is disabled. You can type questions at any time and put them in the Q&A, which is in the lower right of your screen. We've received already a number of questions during the registration. Thank you for those. And we'll do our best to address as many as possible as we go through the presentation and then at the end. Now it's my pleasure to introduce today's presenters, Dr. Marianne Cloeren and Dr. John Dement. Dr. Marianne Cloeren will be today's lead presenter. She serves as the medical director for the Building Trades National Medical Screening Program. Marianne's affiliated with the University of Maryland School of Medicine and has served as BTMed's medical director since 2017. She recently finished serving on the Department of Labor's Advisory Board on Toxic Substances and Worker Health. Dr. John Dement is an industrial hygienist and epidemiologist who specializes in occupational research and studies on the health effects of exposures to workers in nuclear weapons production. He's affiliated with Duke University and has been part of the BTMed program since 1996. That's not a typo. He has also served on the Department of Labor's Advisory Board on Toxic Substances and Worker Health. Between Marianne and John, I'm proud to say that they've been part of 26 research articles published by BTMed in publications such as the American Journal of Industrial Medicine. You can view all of the publications that we have on our website, www.btmed.org. These articles serve to promote increased health and safety measures for construction workers specifically. Without further ado, Marianne, the floor is yours.
Thank you, Miles. Hello, everybody. I'm really happy to be sharing this information with you. Hope you find it useful and interesting. The goals of the presentation today are to explain what the risk factors are and the trends in both colorectal cancer and screening for that disease. To share with you results from our own research related to screening that we do in our former worker program exams, and then also describe different ways that screening can be done and help you understand what can happen, what should happen if a test is abnormal. I think a lot of people are a little afraid of screening, and hopefully by the end of today's presentation, if you are one of those people, you won't have that fear anymore. So what is colorectal cancer? And you'll see it abbreviated throughout this presentation as CRC because it's a lot less syllables. Well, it's a couple less syllables. Don't make me do that. But colorectal cancer is the second most common cause of cancer deaths. It's behind lung cancer. And I think as our smoking rates decrease, we may see that colorectal cancer takes the lead. But it's an abnormal growth in the cells in the lining of the large intestine, the colon. And colorectal cancer typically starts as a polyp, which is a small growth that is precancerous in the beginning, and then can evolve to become a cancerous lesion. Almost all CRC is When you biopsy it, the pathology of it, the type of cancer, is adenocarcinoma. And there are different types of cancer. And this is most important when you get to kind of understanding treatment options, that GI cancers are largely adenocarcinoma. But like many cancers, CRC can grow, it can spread locally, just in the region where it started. It can also spread regionally to, say, the abdominal quadrants, and then it can metastasize. If it's not diagnosed early enough, it can spread to other parts of the body. And we see the same kind of pattern with other kinds of cancer. So this is a nice picture of the intestines. This is intestinal anatomy. And I'm going to start with the mass of snake-like things in the middle. This is the small intestines. They sort of sit almost kind of folded in, kind of in between the colon. We're not going to talk anymore about the small intestines because colorectal cancer really doesn't affect them, but they're in the picture, so I thought I'd better mention them. The colon starts with the cecum, and the cecum is just the very beginning of the rectum, the colon, where it attaches to the small intestine. And then you have the ascending colon, and so it's called ascending because the route that the waste materials take will be moving upward here. So it's moving upward, and then it'll be moving across to the right in the transverse colon, and then go down in the descending colon, and then eventually it reaches the sigmoid colon, and then the rectum, and then the anal canal, which is where it leaves your body. So the colon is kind of named for the route, basically, of the pathway of fecal material. You may wonder what polyps are. This is a picture. The top picture on the right shows you precancerous polyps. So you can see there are two white ones and a reddish kind of one. It's growths. They're growths that can be different sizes. They can start very, very tiny and then grow bigger, but they tend to be very smooth. And when a doctor this is a picture from colonoscopy. So a scope was in somebody's intestine and took these pictures. And when a doctor sees this, they're usually pretty sure that they're not cancerous, but typically what they'll do is take them out and then send them for biopsy just to make sure that they're not cancerous. So these are precancerous lesions that are found during colonoscopy. Any that are found are removed because some of them, if they're left in there, can grow and become cancerous. And so during the procedure, they're removed. And in the report, the GI doctor will tell you how many were found, how big were they, and based on what is found, they'll make a recommendation about how often you need screening. And so if nothing is found at all, everything is totally normal, repeat colonoscopy would typically be 10 years, every 10 years. But if some polyps are found, then they may recommend, and if a whole lot of polyps are found, they may recommend very frequent screening. But often the recommendation is come back in 5 years, come back in 7 years, and it depends on the findings. At the bottom is a picture of what the colonoscope looks like. And it's basically a flexible tube that has a camera. And if you look very closely, you can see like a loop that is, let's see if my pointer works. You see a loop that is used to snag that polyp. And so the scope actually has little operating equipment on it, and so they can take that polyp and remove it and collect it for biopsy. And this is, so remember what the white smooth ones looked like. This is an example of what a cancerous lesion would look like during colonoscopy, and you can see that it's less kind of smooth. The edges of it are less defined. And so when a surgeon sees this, or not a surgeon, but a GI doctor typically sees this, they would normally biopsy it and usually recognize that this is a cancer. So colorectal cancer is staged, and so earliest CRC is called localized. That means that there's no sign that the cancer has spread outside the colon or the rectum. So that picture that we just looked at, as ugly as it was, that might be a localized cancer. It may not have spread anywhere. Regional cancer is diagnosed when testing shows that the cancer has spread beyond the colon or the rectum and has spread to nearby structures like the lining of the abdomen or the lymph nodes. And then cancer is considered distant if it has spread to distant parts of the body, such as the liver, which is removed from the colon, or the lungs, or lymph nodes that are not directly following the colon. They're not directly draining from the colon. Symptoms of colon cancer, colorectal cancer early on, when it's most treatable, usually has no symptoms. An early symptom, blood in the stool may be an early symptom. So blood in the stool is not something to ignore. Most of the time, if you have blood in the stool, it's not going to turn out to be cancer, but it could be cancer. And so we recommend not ignoring that. And so one of the reasons that we do screening is because early colorectal cancer, when it's easiest to treat, usually doesn't present with any symptoms. So it's better not to wait for symptoms. As the cancer grows, it may grow large enough to obstruct the colon. And so if there's an obstruction, symptoms may include abdominal pain, nausea, vomiting. A doctor may, in examining you, find an abdominal mass, or occasionally a person may notice that they have a mass in their abdomen. If you do find a mass like that, that's something to go to your doctor about. Changes in bowel habits is another symptom. It's not usually a super early symptom, but it's something not to ignore, because it's certainly earlier than the symptoms you get if the cancer has spread. But when we say changes in bowel habits, we mean that the shape and the size of your bowel movements has changed, and usually in a direction of getting kind of thinner, because it's having to make its way out around a mass, for example. Later, when usually after the cancer has become more than localized, there may be symptoms of feeling fatigued, having weight loss, losing your appetite. So what are some national trends in CRC? There's a lot of good news. Now that we have screening, we've got very effective screening and very effective diagnosis and treatment. And so the number of people that are diagnosed with actual colorectal cancer has been declining since the mid-'80s. And it may be in part because of changes in diet and things along those lines. And the incidence, like the number of cases, kind of per hundreds, of people, hundreds of thousands of people, whatever we're counting. Anyway, that's been declining in people that are 65 and older. So older people are having less risk of developing colorectal cancer, and mortality rate's been going down, and the survival rate has been going up. The survival rate's going up because our treatment is much more effective. And we're catching cancer at an early stage when it's more treatable. There is some bad news, however, and one point is that colorectal cancer is increasing in people under the age of 50, and we don't know the reason for this fully. There are a lot of theories, hypotheses that are being tested in the research, but it's fairly new news, right? It's only been in the last 10 years or so. And so we haven't fully figured out the reasons for it. Some of it may have to do with changes in our gut bacteria, and changes in diet. It might have to do with chemicals in the food, but we don't know. All of it is still under research. The other point of bad news is we have really effective preventive measures, and we have really effective treatment if we can catch it early. And yet, only 63.5% of those who are eligible for colorectal cancer screening in the United States got that screening. in recent years. So that's a problem. So who's at risk? Genes, our heredity is responsible for about 20% of cases. And if a first-generation relative, first generation is your parents, your brothers or sisters, if one of them has colon cancer, then your risk is 3 times higher. The diet that is responsible for so many problems, so many chronic health problems that we see, heart disease, diabetes, et cetera, is also one of the risk factors for CRC. And so you can see some of the villains on the right. Having a history of certain diseases like familial polyps or ulcerative colitis increases your risk. Lifestyle things like being overweight, sedentary, or smoking increases the risk. And if you have particularly a medical history of pelvic radiation therapy for another cancer, that increases your risk as well. Now, what about work? There are some types of work and some exposures at work that can increase the risk of having colorectal cancer. So some of there's research that shows that exposure to chemical compounds used in processing leather, metal fabrication, plastic and rubber, and also exposures to wood dust and asbestos increase the risk for colorectal cancer. Radiation-related cancers, so exposure to ionizing radiation increases the risk, and so CRC is one of the recognized cancers as part of Part B of the Energy Employees Program. There's actually an increased risk of CRC among firefighters. And so what is it that they're exposed to that increases the risk? That's not totally clear. They've got a mixture of exposures. And then there's very interesting research showing that sedentary work and night shift work, people that do sedentary work or night shift work have increased risk as well. And studies on like long haul truck drivers showing increased risk. So, as we study populations and risk, there will probably be additional kind of information. But related to construction work, there have been 2 recent very careful systematic reviews, looking at lots of different research articles. And these systematic reviews that included something called meta-analysis do support a causal link between being exposed to asbestos and having increased risk of colorectal cancer. So what are the recommendations for screening? Who should be screened? The recommendations at present, and recommendations change over time as research provides more information, different information. But right now, ages 45 to 75, and so you might imagine that this, if we continue to see increased risk in people under the age of 50, the recommendations might start moving toward younger screening. But right now, it's 45 to 75. Now, what about people that are 76 to 85? The recommendations by the scientists that look at all the research and make these recommendations say that it should be an individualized decision, and it's going to be based on how healthy you are and kind of other factors that your doctor can go through with you in a shared decision-making conversation. So considerations would be things like, do you have health conditions that would put you at increased risk if you even have the colonoscopy screening test? Or would you want to have surgery if a cancer was diagnosed? So, would you survive a surgery if a cancer was diagnosed? So all of these things, that you and your doctor can consider should go into the decision if you're in that age range. Past the age of 85, it's generally not recommended because the risks of the screening and the treatment tend to outweigh the risk of dying of it. If you are somebody that has a strong family history, first-degree relatives, or personal illness such as ulcerative colitis that increases your risk, then screening normally would start earlier and maybe more often than the every 10 years colonoscopy. And I keep on referring to colonoscopy because it's really the best test. It's the best test for a couple of reasons. One of them is because if precancers are found, they can take them right out. The other reason is if you do these other types of tests, not colonoscopy, and there's something abnormal found, you're still going to wind up with a colonoscopy, most likely, to try to figure out what's going on. But there are other options. And the other options are something that, well, when I was a baby doctor, what we used to do was the stool fecal occult blood tests, also called the guaiac test. Those are still around. They've become better. They're high sensitivity now. And another test, both of these rely on a stool sample, basically. You have to collect a stool sample, and then drops are put on it that help diagnose whether or not there's blood in the sample. So that'll tell you whether there's blood in your stool. It doesn't necessarily tell you that it's cancer. It just tells you that there's blood there. But if there is blood there, there's a chance that it's cancer, and then follow-up tests would be needed. There's also something called a stool DNA fit test, different kinds, 1 to 3 years, depending on risks. Some people get a computed, like CT. Computed tomography is another, it's the long way of saying CT. So CT colonography. So basically it's a CT scan of your colon every 5 years. So that's not invasive like a colonoscopy, but it's not considered the standard of care. And not as good as a colonoscopy where it can visualize what's going on and take out problem lesions. Flexible sigmoidoscopy, you remember the picture of the colon? The sigmoid colon is the part like right near the bottom before the rectum. And so having just a partial scope in that part of your colon, every 5 years is an option, or flexible sigmoidoscopy plus an annual fit test. There are different combinations of screening tests. The problem with the flexible sigmoidoscopy is, a lot of cancers are found in that region, and so it will find cancers in that region, but it doesn't reach far enough to find cancers that are in the other parts of the colon. So colonoscopy goes through the whole colon. It's a better test. Okay. So what about screening trends? And the data that we have is from 2023. Again, only about, actually, there's a typo there, but 63.5%, I believe it was, of eligible Americans were screened. And it's funny with these slides, you can look at them over and over again and not see typos until you're presenting. You can see by this picture, the darker colors are where the rates of screening are higher. And so the rates of screening are higher, on the eastern seaboard, Minnesota and South Dakota, fairly high kind of across the middle of the country and the Pacific Northwest, lower in some of the other states. So, but everywhere it's not as high as it should be, right? This is people eligible for screening, and nowhere, even in the darkest states here, is it over 70%. So. So overall in this country, if we look at between 2017 and 2021, only about a third of cancers that were diagnosed were found in the early localized stage when it's easiest to treat. If you look at the pie chart, you can see the blue there. About a third of cancers were found. Again, what I just said, localized. About 40%, the orange, were regional, and regional can still be successfully treated, but the success rate is less than if it's very localized. And then over 22% were found when it was already distant, affecting beyond the colon and the region. So we can do better. This shows the survival based on the stage when it's diagnosed. And so the very first blue bar here, overall, what is the survival of colon cancer? Once it's diagnosed, it's a lot better than it used to be, right? But it's at 64.4% overall. But you can see that if we catch it when it is localized, the survival rate is close to 90%. And then if it's regional, so it's spread beyond the walls of the colon and the rectum, the the survival rates goes down a little bit. And then if it's distant, it's a lot harder to cure. So I'm going to turn it over now to Dr. Dement, who's going to describe our research.
Thank you, Marianne. What I'd like to describe is what BTMed has done over the years and our analyses to look at the impact of colorectal cancer screening in our population. Our exams are offered every 3 years, and we've actually offered colorectal cancer screening since the start of the program around 1998. The methods of testing have changed as the science has changed and recommendations have changed over time. And you can see that summarized here. We did the test, the guaiac look for blood in the stool. Through about 2008, we switched to a method that was more high sensitivity, but it was still looking for blood in the stool. Then from 2015 to present, we've used this immune test or FIT test, which is much more sensitive and has other advantages. It has less requirements for restrictive diets and medication use, and only requires one stool sample. We revised our criteria in 2021 based on recommendations and new guidelines to start screening individuals at age 45. Next slide. We conducted a study that we would call a cohort study. Basically, we enrolled people as they did their initial BTMed exam. There's about 27,000 people who were interviewed. Of those, some people choose to do the interview only or delay the exam and not do the exam immediately. Of those, we had about over 23,000 who did at least the initial exam, and many of them did follow-up exams as well. So we analyzed the data, and if you look at the middle, we analyzed the data for over 20,000 individuals who are over age of 45. And what we did, we took each of their exams and we tabulated one, whether or not they chose to participate in CRC screening, and also the method that was used for the screening. And on the far right, you see between 1998 and 2008, over 71% of our individuals chose to participate in screening. Between 2009 and 2015, again, we used the high sensitivity method, it increased to 80%. And as we went to the newer method in 2015, which only requires one sample, we had a really high participation rate of almost 86%. So what our analysis did, we looked at, we followed this population over many years from 1998 through 2021. And we did the follow-up using what's called the National Death Index, which provides information about whether or not a person has died and also the causes of death. So we looked specifically at deaths that were attributable to colorectal cancer. We had information about the demographics, age and gender, BMI, whether or not they had high use of alcohol, and some other risk factor information. And we developed a number of statistical models that basically looked at the risk of dying of colorectal cancer, controlling for things that might confound or confuse the relationship between screening and colorectal cancer. Next slide. So as I mentioned before, we overall had a very high participation rate for participating in our screening for colorectal cancer. Over 77% of the individuals screened overall were in our BTMed program were participating in the screening program. Lowest for the, as I said, for the initial one, the guaiac, low sensitivity guaiac test, but very high for the FIT test. And what we observed in a population is that we a couple of different analyses. We observed a overall reduction of about 61% in the mortality in our population due to colorectal cancer. And another interesting thing was if we specifically looked at reductions by these three different test methods. And we saw reductions for each of the methods, but for the FIT test, we had a very high reduction of around 60%. So the FIT test, which is currently part of the BTMed, has one good participation, and it has, in our population, shown to be a great benefit in terms of reducing the risk of colorectal cancer.
Thank you. Back to me. So what does this mean? One of the important things I think here is that including CRC screening in former worker program exams is a service that really saves lives. It also because we were comparing people that were getting it through us with ones that were not getting it. If everybody was getting the exams that are recommended, through their own personal doctor, then we might not have seen this kind of a difference. So we think that, as we've seen in the rest of the United States, that a lot of people are not getting the recommended screening, through their usual, insurance and doctor. And there are good reasons to include colorectal cancer screening in occupational health screening if the population is one with occupational risk factors, such as ours. And so including this screening in occupational health exams, work-related exams, can help patients get the recommended screening. So the recommendations that I just listed here, again, we went through all this already. I'm not going to read them all again, but age 45 to 75, you should be seeking the screening. It's offered through the BTMed exams, but our exams are every 3 years. And if you're choosing to do the FIT test, the optimal recommendation is getting it every year, not every 3 years. And you may want to consider having colonoscopy through your doctor. And that would be every 10 years unless they find something and recommend more frequent screening. If you're above the age of 75, then it's something that you'd want to discuss with your doctor, and shared decision-making should be used that takes into account your health and your values, what's important to you. So people ask, what's the meaning of it if I have an abnormal FIT test? What are the chances that it's cancer? It's actually not that high. More often than not, when somebody with an abnormal FIT test goes for the colonoscopy, it's usually not cancer, but it's a great way to identify cancer as well. So if you have an abnormal test, then it does need further evaluation, and this is typically colonoscopy, which is performed by a gastrointestinal specialist. Here's that picture again, a little bit closer, so you can see the colonoscope, and with the camera and the light and the tools to take out the polyps if they're found. And so sometimes, they'll find polyps and, send it, and it'll be not cancerous, and there'll be an explanation for the bleeding. Screening colonoscopy is one of the alternatives. So as with a lot of cancers, sometimes the same tests are used for screening as they are for diagnosis. And so a screening colonoscopy is every 10 years, unless there's some kind of findings, right? But what we're talking about here is a diagnostic colonoscopy. It's done exactly the same way, but the reasons for it are different. The reasons for this colonoscopy on this slide are because of an abnormal other type of screening test. So a diagnostic colonoscopy would be used if there's an abnormal finding on a FIT test, or if you are reporting blood in your stool. Typically, this would be part of the workup for it. If you have worrisome symptoms like anemia, which is can be a sign that you're losing blood, and sometimes that blood is being lost in the stool, and so slowly that you're not seeing it, like not visible blood. Anyways, symptoms like that are all kind of indications for a diagnostic colonoscopy typically. And some of that's dependent on your age and you know, the workup that your doctor decides to do. So what if you are going for a colonoscopy? I think probably most, well, I don't know about most of you, but many of you that are listening in on this have had a colonoscopy already. So you're familiar with this. Some of you may have been scared off about it, but typically you have to fast for a while, but it's not that long, right? And then the worst part of it, in my opinion, having been through it, is the bowel preparation. The bowel preparation is typically something that you drink that causes you to empty your bowels, because your bowels have to be empty for the doctor with the scope to be able to see anything. And there are different types of prep, and different GI doctors have you know, different preferences for how to prepare your bowels. But this is it, basically. You can't eat for a little bit, or you can only eat things like Jell-O. And then you have the bowel preparation. And then the procedure is done in an outpatient center. You don't have to be hospitalized for it. You are sedated for it, and so you're not going to notice anything during the procedure. They do make sure that you stay hydrated during it, so they'll start an IV and give you some fluids. They do the procedure. If they find polyps, they'll take them out. They may take tissue samples. They'll take pictures. And then because of the sedation and just kind of the procedure itself is taxing, you'd have to make sure that you have a ride home. And then the follow-up is done just kind of based on the results. And you often find out pretty quickly what the results are. I think that these diagnostic tests have gotten a lot better at, you know, kind of prompt reporting. So this is our final slide, and then we can go to Q&A. But basically, this is the whole presentation by the numbers. The colorectal cancer screening that we've been doing is saving lives. Age 45 to 75 is definitely should be screened. FIT test needs only one stool sample, and it will detect 70 to 80% of colorectal cancer. Because it's, and this is part of the reason that it's done yearly, is you know, if it's missed one year, then hopefully it'll catch it the next year. And colorectal cancer tends to be sort of slow growing. 90% of those who are whose cancer is caught at an early stage are still alive 5 years later. Excellent survival. National participation is low. Well, it's not as high as it should be, 63.5%. And so, you know, a lot of people that should be getting screened aren't, but our participation has been very high, and our outcomes, especially using the FIT test, have been good. We've found a 61% lower risk of dying of colorectal cancer in people getting screened by a FIT test. So I'm going to stop sharing slides now, and I think we can go on camera and have Miles guide us through the Q&A.
We did. When I came back on camera, I wanted to have all the food that you had on that one slide just on my desk. You're not listening, Miles. But I mean, that lends itself. I know these presentations, these webinars, one thing I love about them, I know they're geared toward our former worker populations, but they're really, I mean, they're webinars that everybody should watch because in some way, shape, or form, it affects every individual, and it's worth, you know, gaining a better understanding of these topics. We got some really great questions in. Some of them Marianne addressed during her presentation. And thank you to both of you, Marianne and John, for an excellent presentation. But I wanna touch upon those again, just because multiple people had some of these questions. And to start, why is there now more colorectal cancer among younger age groups of less than 50?
I think the answer to that is stay tuned. It's a recent enough recognized development that we don't know the reason for that. There's a lot of research going on to try to figure it out. Some of the thoughts are that it has something to do with the balance of microbes in the gut. Some of that is affected by what we eat. may be related to things in the food that we eat. It may have to do with increased obesity, but we honestly don't know the answer to that yet.
And then one question we've gotten a lot of is on the other side of the age group, at what age does screening stop?
The government recommendations are that after the age of 75, that it should be discussed with your doctor because of the balance, between risk and benefit. And actually, I see in the Q&A a related question, so I'm going to just go to that now. Someone asked about the overall risk of cancer versus the risk of complications, and especially as we get older. The procedure, the sedation that is used for the procedure, it's not general anesthesia anymore. It's a much safer way of sedating you. So it's not as high a risk as going for an operation where they have to actually put you out and monitor your breathing, monitor your vitals. I mean, they still do all that kind of stuff, but they basically put you into a twilight kind of a state. So the procedure itself is pretty safe. Most of the decision making is around what you would do with the results. So if it is found, are you well enough to have surgery for it, for example? If it is found and, if you're having, or if you're already having symptoms and it's a diagnostic colonoscopy, then it may be a different kind of situation. So I think there's just like so many variables, and each of us has different kind of medical conditions, and each of us has different values and what's important to us. Like for some people, it may be just really important knowing that there's not a cancer. I don't have a cancer there, thank goodness. That's really important to them. But for others, it may be more important to have like a decent quality of life and not have to worry about surgery and chemotherapy. And like if something was diagnosed, maybe they wouldn't choose that anyway. So that's why it's really recommended after the age of 75 that you have a decision-making conversation with your doctor who presumably knows your health very well and can help you kind of weigh the pros and cons for you.
All right, and we had a few questions come in during, and some great questions that came in for registration. I'd like to go with some questions that came in during. I'd like to know if the screening is free for those who are eligible.
If you're yes, I mean, if you're a former worker program and your program is doing the screening, then yeah, it would be free. But also if you have health insurance, you have Medicare, typically cancer screening is free. And if you don't have insurance, and maybe you're not, if you're somebody listening and that somehow doesn't have insurance, doesn't have Medicare, there are a lot of health departments and universities offer screening programs for people without insurance. So one way or the other, you should be able to get screening for free.
And then also, what if someone is not up to the age of 45 and wants to be screened for it?
Insurance would not cover that typically unless there is a reason, based on medical risk, for example, someone with ulcerative colitis or family history. It may not be covered by insurance. And so that might, influence your decision about, fit versus colonoscopy, which would be significantly more expensive. But I think that'd be a discussion with your doctor. If there's good reason for it, the doctor can usually get approval for something like that.
All right. We have a question about what percentage of former workers are being diagnosed with colorectal cancer.
I'm going to let John handle that one.
Yeah, I think the formal answer would be that's really not known because the former worker programs themselves don't capture information on the incidence of cancer. However, within the BTMed population, we do capture information on colorectal cancer mortality. In our population, those who don't participate in the screening programs, about 3% of those have died of colorectal cancer. And those who participate in the BTMed program, where we offer colorectal cancer screening, that's reduced by a bit more than half.
So it is effective. Okay, our next question. Has there been an association or suspect correlation found between colon cancer and exposures at DOE facilities?
I don't know of any research that particularly looks at DOE as a workplace and workers, but certainly radiation, ionizing radiation exposure is a recognized risk. And so this type of cancer is included in the special exposure cohort diagnosis list. And also, in BTMed's cohort, asbestos exposure would be one of the risks, that construction workers would have had at DOE sites and elsewhere. John, do you do anything to add to that?
Yeah, I think that's a good summary. I think the evidence with regard to occupational exposures in colorectal cancer comes from the overall epidemiology, and as Marianne, I think, mentioned early in the presentation, there's a recent really detailed review of asbestos in colorectal cancer, and there's a really a good strong relationship between asbestos and colorectal cancer, and there's reasonable evidence for things like wood dust and some metal exposure. So these are all exposures that construction workers will have.
Right, thank you. On to the next question. As a DOE former worker, is there an exposure I may have had, such as beryllium, that might increase the odds of fast onset colon cancer?
I think that I'm not aware of beryllium being associated with colorectal cancer. But if you're a construction worker, then you worry about asbestos, potentially wood dust. If you had ionizing radiation exposure, that would be a risk. And as we're doing more research, other risks are popping up. But and I'm not sure what is meant by the fast onset. I don't know of anything I don't know of any research that shows that particular exposures will increase kind of the quickness of development of the cancer, or how quickly it becomes more severe.
All right. Next question. Is there a higher risk category, i.e. by ethnic group?
There is increased risk of colorectal cancer among Black Americans compared to white, and also Native Americans. Our data didn't include enough of people in those ethnic groups for us to be able to see that. But like looking at national data, there is increased risk.
All right. The next question we have is a little more related to the Department of Labor's COMP program. It's does anal cancer count as colon cancer, which is a covered SCC cancer?
Most of the time, anal cancer would be considered, the anus would be considered part of the rectum, but there are some types of anal cancer that are considered skin cancer. There's some anal cancer that is caused by a virus, for example. And so if the diagnosis is one of those types of anal cancer, then it probably would not be. So it's up to the Department of Labor to make that decision.
Yeah, I think in that respect, it's up to the Department of Labor's input and on an individual basis, and I think it can get pretty complicated. So the answer can be different on an individual basis.
Yeah, it depends on the medical documentation and what it says about the kind of cancer.
All right. The next question we have is, what are the recommendations for colonoscopy versus Cologuard? In general, the colonoscopy is the best test. It's
Is it going to be the best test for every person? No, there are other considerations. But because colonoscopy can visualize and then also remove the precancerous lesions, that's a better test. What we like to say is the best test is the one that you'll do. And so some people are like, no, I will not do a colonoscopy. I do not want that done. And so, if then that's has to do with your own values and your own feelings, and that's all legit. And so getting screened a different way is fine.
Right. The next question we have, should a person older than 80 who has a few non-cancerous polyps be concerned about them becoming cancerous?
I think it depends on that person's history. Is this somebody that, has been getting screened every 10 years, and every 10 years they find a few non-cancerous polyps and the doctor says, don't worry about it? That's one situation. This is the kind of thing where I think it should be discussed with the doctor.
Right. We have a few more questions coming in. One is pretty general. Can I order a fit test?
That is a good question. I'm guessing you can. Well, you'd have to have a lab process it. That's the problem. So typically it's through medical supply kind of channels. And so I'm not aware of an ability to just go ahead. I don't think you can get it on Amazon and get it processed. I could be wrong though. Amazon is starting, this is not a commercial for Amazon, but Amazon is kind of getting into the medical world. And so it is possible that they're offering, such screening. Maybe.
Okay,
it's not something you can like go to the CVS and pick up, or Rite Aid or any other store. I'm not making a commercial.
At the very least, this next question, is this testing available through BTMed every 3 years?
And that answer is correct. Yes.
Yes. If you are one of our participants. Okay, next one is not so much a question as they would like you to elaborate on a few words about the detrimental effects of alcohol use.
Well, I mean, alcohol is a toxicant, right? It is processed as in the body as something that the body doesn't need, that the body doesn't like. And although there may be a few studies here and there that show, red wine can, be good for the heart, on balance, alcohol use is bad for the brain, is bad for the liver, and increases the risk of a whole bunch of different kinds of cancers. So the current recommendations by the Centers for Disease Control around alcohol use are that women should have no more than 7 standard drinks, which might be a glass of wine, a can of beer, no more than 7, and that's not a day, that's a week. Women should have no more than 7 in a week, and men should have no more than 14 in a week. That doesn't mean that's not the same as the recommended daily allowance. It's not like a recommendation that you drink that much. It's the max that is considered safe.
Yeah, I would just say in our analysis, we did control for what we called excessive alcohol consumption. That was more than 2 drinks per day, and we did see an increase, sort of relative risk of about 30% for excessive alcohol consumption. And that's consistent with the published literature. We're not the first studies to find that. It's very consistent with the published literature.
All right, well, speaking of published literature, you two would be the ones to maybe field this question if you know the answer. What is the most compelling journal article or research reference regarding asbestos exposure and colorectal cancer and other cancers?
Wow.
That's a hard one. If you go to our paper, you can see the citation list. That might be a really good place to start. I don't know if I have a favorite paper. John might.
I think probably the most recent review of colorectal cancer that I'm aware of is published in a journal called Occupational Environmental Medicine. And it is referenced in our manuscript. So I don't have it right here in front of me, but you can find that reference there. With regard to other cancers, I mean, there's about 10,000 reviews on asbestos in the world. And I would say with regard to some of the cancers, the most recent EPA risk assessment on chrysotile asbestos might be a good place to start. If that hasn't been, if it's still on the website, but it's on the EPA website.
All right, I just put the link into all of our published medical findings, and that was a good point. I'll include it in the follow-up email that goes out with this, with the recording and the other links.
Yeah, you might want to also add that the most current IARC review, WHO IARC review on asbestos and cancer is very authoritative, and I would highly recommend that.
All right. Well, I think unfortunately we're running out of time here, and before we wrap this up, if we didn't get to any of your questions, please feel free to email us. There's email information on the Former Worker Program website. There will be email information also in the follow-up email that comes out. I just want to take a moment to especially thank those who helped out on putting this webinar together. Loki Harmon and Greg Lewis from the Department of Energy, along with all the other former worker programs and their coordinators who were a huge help in spreading the word and promoting this webinar. I also want to thank CPWR, the Center for Construction Research and Training, for allowing us to use their Zoom platform for this webinar. You probably saw the logo flash up there when I took my video off screen while Marianne and John were presenting. When you leave this webinar, the web browser is going to automatically redirect you to a short survey that'll just take a few minutes. We'd really appreciate your feedback. We go through all of it, and especially any topics that you would like to see on future webinars. So it points us in the right direction when it comes to that. And again, touching upon topics for future webinars, make sure when you get the follow-up email, you explore the past webinars that we've done. Because like I said, even though they're geared toward the former worker population, they're great for anybody, everybody to watch, whether it involves lung function or hearing, maybe not so much beryllium exposure, but the CT scan side of the programs. They're really valuable for everybody to watch, very informative. So on behalf of the DOE Former Worker Program, thank you very much for attending today and for your time and attention. Thank you, Marianne and John, for an excellent presentation. Really well done. Please reach out to us with any questions that you may have had that we didn't answer. Thank you and take care.